right. Okay, Samantha, can you hear us and can you see the PowerPoint? Perfect. Okay. All right. If you guys can help me keep track of the chat, sometimes I don't see it. All right. So get this away. All right. So don't forget there's a D2L evaluation or wherever you guys, it's not D2L. Our objectives, we're going to talk about the USPSTF recommendations. Your questions that you guys will be answering will be based on those guidelines, so you'll need to know them pretty well. If you go to the CDC website, if you have any questions, that's an easy way to quickly find them. You'll be able to know by age the recommended set of things you should go over during the preventive care visits. You should be familiar with the ways that we determine the hypercholesterol and cardiovascular risk assessments and treatments for that, and utilize accepted methods of counseling in the primary care office, be able to identify correct milestones in children, identify ages for vaccinations, and discuss the importance of vaccination. Okay. You guys had your Bob review case. Do you guys have any questions about that? If you don't, it's fine. Most people don't, but if you do later on, let us know. Okay, so question number 1. What do you guys think? That would be correct. The longest answer is often the correct answer. But that is correct. So it's guidelines, and we'll kind of talk about that here in a second with some of specific examples. But just because it says A doesn't mean you have to do it. Just because it's an I doesn't mean you can't do it. But you want to use your judgment, and because they have the different grades of recommendation for reasons. So for the most part, it is what we follow, but not set in stone. So something you kind of can call this a protocol, you know, guidelines, protocol, recommendations. It's something that I have to go over with my residents all the time. Just had 2 different conversations with a resident last week regarding protocols and how protocols are protocols. They're not the end all be all. And that's why we go to medical school. We use our brains to know, okay, this is whenever the protocol doesn't make sense, because you can make exceptions to the rule, right? Let me close this thing. But there are times when you might break protocol, but if you have reasons to do that, then that's fine. But it's to guide you, not to make the ultimate decision for you, right? So this is an example of what you would see: A, B, C, D, and I. And you'll see that here in a little bit. So with the Bob case, it's a 41-year-old, no immunization since high school, has diabetes. What would you do for him? Tell me your guys' thought process. Mm-hmm.
But he said diabetes.
Mm-hmm. Right. Yep. So your thought process is exactly right. So the hepatitis B, if he got his regular immunizations, then he should not need it, right? And it says that he's had his last immunizations in high school. So we're assuming that he is up to date through high school. So he should have had those well before high school. So we would think that A would be the right answer because of that. You're absolutely right. Okay. So here is basically what you kind of went through. So the Hep B is if he was unvaccinated for some reason. And I actually have a couple of this wording can get kind of confusing just reading through it all. I have an algorithm sheet for you guys. And for the Zoom people, I'll have Shandy post these on Leo. It's a pneumococcal vaccination algorithm sheet, and we'll post that shortly after this. I'm sorry. That one. And I don't think I have another way to show this. But basically, you look at the age of the patient. If they're 19 to 64 and have an immunocompromised condition, CSF leak, or cochlear implant, then they would fall all the way to the left side and they would get the Prevnar 13 and the Pneumovax. And it would be 8 weeks after the Prevnar 13, 8 weeks later, they'd get the Pneumovax. If they don't have any of those left side column conditions that are basically immunocompromised conditions, they just have other types of chronic conditions, including heart disease, lung disease, diabetes, alcohol, chronic liver disease, or smoke cigarettes, then they would just get that one-time Pneumovax or the PPSV 23. And then they're done, okay? Then when any patient turns 65, so this is any patient with or without any of those conditions, then again, they would get the 13 and the Pneumovax 6 to 12 months later. We usually do 12 months later, kind of to make it easier. But this, out of everything that I looked at, this seemed to kind of summarize it up the easiest. So I wanted to give you guys that sheet. So it's not in the PowerPoint, so I apologize, but if you want to take a picture of it or whatever, it'd be a good resource. Okay. Which of the following preventive screens is recommended for a patient like Bob, who's a 41, non-smoker, presumed to have diabetes and hypertension? Okay, so talk me through the other options. So for Zoom people, they said E, lipid disorders. Oh my gosh. Sorry. Okay.
Not an increased risk for osteoporosis. Skin surveys not recommended. And it's overflowing disorders and venous comorbidity.
Okay, so for Zoom people, he's not 45. For A, prostate cancer screening is debatable. Osteoporosis doesn't have risk factors that we know of. D, skin survey is not recommended, but E would be recommended due to his age. So we're going to talk through some of these. So this is kind of what I've been talking about with every group, because it's still a grade B recommendation for 45 to 49. 50, it's clear cut. Absolutely need to be doing it if they haven't already. sooner if they have family history. 45 is a B recommendation. More and more of us are moving towards being able to do that. But not all insurance has caught up to that is one of the problems. So we kind of just have to put it in the referral and then see if they get it pushed through or not. It's still a discussion that we're having because a lot of patients aren't used to that. When we have that discussion, like, oh gosh, I thought I had another 5 years. So they're not a lot of the time mentally prepared for that discussion is one of the other problems that we run into. But it does give you the opportunity to talk about the options. What methods do we use for colon cancer screening? Colonoscopy,
Fecal occult blood test,
fecal occult blood test,
Cologuard.
Cologuard, sigmoidoscopy. Sorry, I'm repeating you guys for the Zoom people. So if they do a colonoscopy, everything's perfectly great. When do they get another one? 10 years, perfect. If they do FOBT, everything's great. When do they do another one? Annual, yep, 1 year. And you technically have to bring 3 different stool samples. So it's a little cumbersome. Yeah. So if you can imagine, not everybody really likes that option. I have had one patient that still to this day chooses to do that. Although I don't think the lab is actually giving her 3 different containers, but I don't know, because Cologuard is essentially the same thing with just 1 sample. And if it's good, when do you repeat that? 3. Yep. So I have really liked the Cologuard as an option. And to be fair, I actually haven't seen her since we've pushed the Cologuard screening guidelines, but so maybe she would opt for that now. But the the one barrier that I've run into with that option is that, especially in our patient population, I had one patient that their package kept getting stolen. Surprise, it's the Cologuard. So yeah, that otherwise I've had no complaints. Everybody absolutely loves that option instead of having to, the biggest complaint is drinking the prep, right? The actual procedure itself isn't usually a big deal to people because they like sedate you or put you out completely depending on where you go. But the prep is the biggest complaint. So you don't have to do a prep for it. It's fairly simple. All right. So some caveats, like you guys had said, so if they have family history, this gives an example that you would start at, if they had somebody diagnosed under 60, that you would start screening at 40, but really that's confusing. It's just whatever. So if somebody was diagnosed, has a family member at 40, when would you start your screening? 30. Yep. If it was 30, then you start at 20. So 10 years prior to their diagnosis age. So that's why it's also super important for you guys whenever you are getting histories, family histories, to find out ages. That's one common thing that I find that medical students forget to gather. And then there's caveats for other things, not as common, but like polypectomies are pretty common. I actually have another handout that, again, we'll post it on Leo for you guys. And then for future PowerPoints, the problem is there's different people that do these presentations. And so I don't know that they'll want them in there either, but kind of a general rule of thumb is after polypectomy, about every 3 to 5 years, or if it was not a proper clean out, if they're like really backed up and that one clean out wasn't good enough, then they'll have you them repeat it in 5 years instead of waiting the whole 10. But actual time to repeat things is dependent on the size, the type, and the number of polyps that are found. So you'll want to pay attention to the path when it comes back, and then look up when their recommended next screening would be, but basically 3 to 5. Thank you. Okay. Prostate cancer screening. It's, again, like you guys said, a very debatable. 55 to 69. After 69, it's recommended to, it's not recommended. 55 to 69, it's a conversation to have. Men expect to have that conversation. They expect to have the exam, which isn't super necessary. If you're a go to a urologist, they're going to do the exam. But as a primary care physician, so much of it is based on the PSA anyway. It doesn't matter what we're feeling, that we're going to order that PSA. So, and that is, you know, a conversation to have, that if they have no risk factors, no symptoms, nothing's going on, no family history, then should you do it? Maybe, maybe not. It just depends on the conversation that you have with them. You want to tell them that, because there is risk of getting the PSA with over treatment, causing difficulty with erection, fertility, and depending on what kind of treatment, surgery, all of that, with increased chances of stroke, heart attack, and death. So that's why a lot of different screenings have changed too, like with pap smears, for example, that we used to, it's changed multiple times, even during my residency. So I don't know if it's on this PowerPoint or not. So if not, we can talk about that here in a little bit too. But lots of it is based on history of over treating people and unnecessarily. And so it's kind of hard to get that across to patients. We're like, well, why wouldn't I test that? So whenever I do have the discussion, a lot of them do end up wanting to go ahead and check, which is fine because it's up to them. But because then they, again, they can have another discussion. If it is elevated, then I send them to urology for surveillance and consultation. And then, you know, just because we do test it and find something, again, doesn't necessarily mean they have to have the treatment. They can have another risk benefit conversation at that point too. But it's a conversation that they deserve to have. Okay. So for men, like somebody mentioned, it's not recommended. There's insufficient evidence to support screening. But with women 65 and older, they do recommend it's a B grade screening. But you do screen earlier than 65 in what circumstances? Mm-hmm. Yeah. That is. Mm-hmm. Any other ones you can think of? What?
If someone goes early.
Early menopause. Yeah. If a lot of the time they're not taking out the ovaries. So if they are, then that is a consideration you could have. Yeah. The biggest thing is making sure that, especially as a primary care physician, that you are having them supplement with vitamin D. I don't know how many people there are that I see all the time that have been going to the doctor for years, and I'm not the best at always asking either, but they're not even taking a multivitamin. Like a doctor has not even recommended to them to take a multivitamin. And in theory, everybody should be, right? Because none of us are eating exactly the right nutrients with exactly the right portions and getting in exactly the right things that we need to be eating. Maybe there's people out there, but vitamin D is very commonly a problem with a lot of people. I screen for it. I have a very low threshold for screening for vitamin D insufficiency or deficiency, because low vitamin D can cause so many problems. so osteoporosis is one, right? But if you have, so it just looks really bad on you as a primary care physician if they go and they have osteoporosis and you haven't even checked their vitamin D, haven't recommended that they take vitamin D, they're not on a multivitamin, just looks bad. But I have women in their 30s that really don't have risk factors, but they're talking about that they're really tired or their periods are really weird. Then I check for vitamin D, and sure enough, it's low or crazy low. Because we're not getting it in our diets. And I have people literally that, or depression is another one that they can tell a little bit. I'm starting to feel depressed. I think my vitamin D is low, and we check it, and sure enough, it is. And so, screening for vitamin D is another one that it's on the CDC website. There's not really, I think it's an I recommendation. Personally, I screen for it, but it's not something that you are technically recommended to do all the time. But at that point, it's not really screening, it's diagnosis. So that is one thing to also keep separate. So if you have a male that comes in and is having weight loss and abdominal pain, and he hasn't, so, and we'll say he's 60, has never had a colonoscopy, is that a screening or a diagnostic colonoscopy that you'd be ordering for him? Yeah, it's diagnostic. Even though he hasn't had one, he's due for a screening, but you're trying to diagnose the problem, right? And insurance codes it, bills it differently. But so that's another way, like, so technical screening for vitamin D deficiency is not recommended, but I'm doing technically diagnostic testing for vitamin D deficiency. So that's how you can kind of explain it, but you'll learn more about that as well as you guys progress and deal with billing stuff. Okay, so different categories with osteopenia, osteoporosis, and then severe osteoporosis that you can see there based on their scoring. And we have here our endocrinologists are the ones that do the blood mineral density testing. All right. What do you say for this question? Why is it LDL cholesterol? So everybody type in ASCVD calculator. And I use the MD Calc one. You can use whichever other one you want, but that's the one that I tend to use.
I did a couple of different ones, and they were so different. And sometimes it'd be like 1%, and then other ones would be like 20% for Bob.
Did it ask the same?
Yeah, I see. So I think I'm doing this about like 5%, but then I got up to date and they kind of sports.
Interesting.
But theirs is not this efficient. They use like a lot of seed stuff, but.
Okay.
Oh,
Okay. Are on the LDL one is on there?
yeah.
The LDL one?
Says stuff, well, I'm using the ASCVD risk algorithm. It says LDL cholesterol greater than or equal to 190. You put yes or no.
Okay, so that's technically not part of the ASCVD calculation, that's just a separate caveat that if they have an LDL greater than 190, then you don't even have to calculate their score.
Okay.
To calculate their score, it's these other questions.
Oh, okay.
So they're trying to be more inclusive by asking that question, which is great. It's just not one of the technical ASCVD calculating factors. Okay. So, okay. So before we used to look at their LDL, their total cholesterol and say, oh, your cholesterol is high and start them on a statin, right? That is not how we do it anymore, which is weird. And a lot of patients don't get that anymore. There's a lot of people that still are on statins and shouldn't be. And so I've been having to slowly like take people off of it because they were started on previous guidelines. And so it's another thing that's kind of hard for people to grasp. And of course, in another 10 years, things will probably change again. But that's why it's important to keep up with like your CMEs and stuff. But as of now, this is what we use. Okay. So you guys know how to do the calculation stuff, right? Is this the one that you guys calculated it for your group thing? Okay.
So question, what is supposed to be like calculated? Is it for my sister, like,
I don't know that I even know what the formula is.
okay,
So
I like, why do I not just calculate?
yeah,
But I don't-
no, I would, so I have to tell you that like I haven't seen your guys' actual shelf exam, so I don't know what questions it actually asks you, but I can't, there's no way that I would imagine that anybody would ask you to do it without a calculator.
I have to be.
Good point.
Okay. Okay. So let's see. Sorry, did one of you guys still need that? Not smoker.
Empty.
Right. Sorry. So you guys want to do it? Okay.
I have it. 6.6 is what I got.
Non-smoker, total cholesterol. Sorry, I don't have this answer. HDL 50.
Another one. I saw.
Yeah. So 6.5. All right. Okay. So so do you start him on a statin or no?
I was gonna just guess, yes.
Why should you?
Comorbidity,
Which one?
the yes. Yeah.
So diabetes, because of the diabetes, that automatically gives him a statin. If their LDL is over 190 or they have diabetes, automatic statin. If they don't have those things, then you calculate their score. And if it's over 7.5 or over, then you start them on a statin. You always want to start low intensity, even if their goal is to be moderate intensity, you start low because some people don't tolerate statins. Almost never does that happen, but it's something that you want to let their body acclimate to. It's just a good rule in general to start people low and then titrate up with antidepressants, with hypertensive medications, all around. I know this is not a psych talk, but I see so many people including psychiatrists that start people on middle of the road psych meds, and then they come back and see me and we're like, I hate that medicine, I never want to take it again. And it's because they started them on too high of a dose. So I start them low and I'm telling them, like, if you can't tell a difference, that's fine, that's great, because I can always go up on it. I just don't want them taking it and saying, I hate this, I never want to take it again, I felt like a zombie or whatever, right? So that's my general rule of thumb for everything. So start them on a low intensity and then work your way up. Okay. All right. Which one of these would you put on a high intensity statin? Why C?
Yeah, right, exactly.
So why not B? That's true. So C is not the right answer because they're too old. After 75, you want to assess the risk and start getting people off of medicines, because at that point, their cholesterol is probably not going to be the thing killing them anymore. Okay. So this is basically what we talked about. In an algorithm form, but if you want to see that, that's great, that's fine. But basically what we talked about is what is in this chart. But that's where that 75 is on there. Sure.
Anybody with diabetes are gonna automatically put on statin.
Mhm. Yep. If they don't, you'll get papers saying you're a horrible doctor, they have diabetes, why are they not on a statin?
There's no like age cutoff for that. It's
Yeah,
just
just like everything diabetes, statin.
That's a good question. I
45.
I don't really have people with type 2 less than that age, so I've never had that question. Well, but this guy's 41 and we put him on a statin, so it might be 40 and above. I don't know the answer to that question. That's a good. Oh, is it on there? Type 1 or 2 diabetes, age 40 to 75. Yeah, so it must be 40. Yeah. Less than that, a lot of the time it's type 1, and I don't see a lot of those in my clinic. Okay. So this is another form of the same thing. So, and here's some examples of low intensity versus moderate and high. So my typical go-to, I'll usually just do atorvastatin 20. It's just very common, very well known medication. So I do 20, and then if they're doing fine on that after a few months and I see them again, then I just increase it to 40. Okay. But also because, sorry, for example, like anything besides atorvastatin and rosuvastatin, there is no high intensity option. So you'd have to switch them to a different medicine. So I don't really like doing that if that's my end goal. Okay. Cervical cancer screening. Let me go back so you guys can cheat. What is the guidelines for cervical cancer screening?
Until
With psychology.
Mm-hmm. Yes, very good. So 21 to 29, every 3, you're just doing the pap smear. Then 30 and above, you're doing pap smear and HPV co-testing is what it'll be verbalized in your question stems. And that's an example of something that has changed again, that a lot of people don't understand. Number one, because even I have medical students that don't realize that a pap smear is something that people will use synonymously with like a pelvic exam. We'll say, oh yeah, I had my pap smear last year. And really they just had a pelvic exam last year, or they had their ST, like every time they got STD testing, they think they had a pap smear. And that's not true. And it's just something that we have to like just re-educate people. And they'll say, oh yeah, I get my pap smear done every year. I'm like, probably not. But I have been proven wrong, because there are some people out in the community that, one, don't know the guidelines have changed, or two, know and don't care and are still just doing it every year. Which insurance may or may not like that, but we used to, it used to be if they were 18, then you would do it, or if they were sexually active or not. And then the other thing was you would be if they were, once you were sexually active, so you could be 14 sexually active and you do a pap smear. But that is another example of things that have changed, because like HPV, those would be abnormal, and studies have shown that people under 21 tend to just clear those abnormalities on their own if you don't do anything. But those people were getting like colpo and leaps and, being tortured basically for things that would have just gone away. And so they've kind of found that as of now, the magic answer is 21. Again, might change after we get more and more research back. All the guidelines are based on research that changes and changes and changes things. So we'll see how that goes. But like the Mirena, for example, is something that keeps changing with how long it's able to stay in because of research. So it's very neat. Okay, so aortic aneurysm screening, 65 to 75 if they've smoked, for men. Breast cancer screening, something that we didn't talk about yet. Says 50 and older. I use closer to 40, but it depends on the women. A lot of them hate doing it, and it's hard to convince them to do it too. But if they have other risk factors, so family history, personal history, anything like that, then I would definitely go closer to 40 years. Depending on their exact history, it could be even younger than that. But if this is the general guideline, talked about that. Hep C virus, it's one-time screening for anybody born between 1945 and 65. HIV screening, basically anybody that one asks for it, might be concerned about it, or they had unprotected sex, any reason that you can find HIV screening. And I'll tell you, in Oklahoma, syphilis is a huge problem. And so like we've really ramped up our screening in pregnant women, where we screen. It's been normal protocol to screen at their first visit for syphilis, and HIV we check, but syphilis is the only one that we really check again at the end of pregnancy, and then again at the time of delivery, because it's been so bad. Because we have like a syphilis task force for Oklahoma that I'm on, that we're really trying to reduce the numbers, but we'll see. Then lung cancer screening. Again, this is something that is why whenever I teach Clin Med, I have you guys make sure to ask their PAC year history, trying to determine their PAC years. Because if they So 50 to 80, if they have a 20 pack year smoking history. I don't know if this is updated. Somebody look up guidelines for lung cancer screening. There's something that's changed. I don't know if this is updated or not. I think it used to be 55 to 80 and now it's 50 to 80. So I think this is the current one.
25-year history, currently smoker, or quit with after 15 years.
Okay. Okay. I wanted to make sure that that's right. This, it used to say 55 to 80. So this is right. Good. Okay. So yeah, so you want to make sure. And then if they do fall into that category, it's a every year screening that they do. And this is another one that I don't see done as often as it should be. Okay. You guys have an answer for this question?
Yeah.
Could be.
Any of them.
That's right. I'll be honest with you, I had not heard of like any of these before. So moral of the story is find a method that works for you, because you guys will be doing a counseling OSCE, like I talked about with you guys first day. You want to make sure that you are, remember, go through all of the history, go through all of your transitions, do your summarizing, so that you can gather your information to do the proper counseling. But you still want to show empathy. You want to relate to the patient somehow, develop good rapport, right? So that they can trust your counseling. If you don't have good rapport with somebody and they're a smoker, and you tell them to quit smoking, or like try to help them to quit smoking, they're not going to want to talk to you about it, right? So any of these methods would be totally fine, just as long as you are hitting the main things, with trying to help them establish reasons why they need to change what they're changing without making them feel bad about it necessarily. Like, you're not trying to shame them, right? You want to help them realize the importance of it without shaming them about whatever's going on. Right. And then develop goals and give them ideas and tips of how they're wanting to change whatever is going on. Right. Okay. I'm going to skip through some of this. Okay. So moving on to kiddo stuff. Have any of you done your peds rotation yet? No.
Surgery and medicine.
Okay. So trying to remember that, again, even with little kids, you have to develop rapport, and with like a 9-month-old, it's a very different way of developing that, or a 2-year-old, it's very different, right? But number one, and try to let the kiddo stay with the parent as long as possible. When I'm doing all of my talk, like sometimes I walk in the room and they try to like, go ahead and like lay the kid on the table. I'm like, oh, no, go ahead and hold baby, because I don't want them screaming and crying the whole time. So we get talk through it, and then the child sees like, okay, my mom is talking to them and they're friendly and this is a nice person. And then like the rookie mistake I made earlier today, you want to try to listen, like do as much of your exam as you can while the parent is holding the child. One, again, because like if you're trying to auscultate the lungs or the heart, especially when the baby's screaming, it's impossible. So if the child is being held at the same time, then it's usually great and it works fine. But the other trick that I do is listening to the parent first, and like, so that they see, okay, this doesn't hurt my mom. She's letting them listen to my mom and nothing's happening. So that's fine. And I do that like with the ears, just depending on what I need to do with the child. So that's one technique I use. And like it says, listen on the skin. Our nurses and MAs have them strip down to do their weight, and then they tell them not to redress them until I'm done. So that's usually not something that I have to go back in and say, okay, let's take all these clothes back off. But that's the main thing really with that. So when we're doing the little childs, you want to assess their motor skills, language skills, social, problem solving is another one, and so language or communication, and talk about what they're doing for their diets, and if they're young enough, so how much formula or breast milk are they drinking and how often, and then how many stools or urines are they having in a day. 4 stools or less in a day is definitely a problem, or sorry, 4 urines or less in the 24-hour period is problematic, shows signs of dehydration. So you want to ask those questions every single visit. And this is very small and a slide that I couldn't replace before today, but I think this isn't a PowerPoint that's on Leo. So kind of goes through the different things that you're going to be looking for. So the big thing at like the 6-month mark is that they can sit up without support. And around, so they're going to see you at 2 months, 4 months, 6 months, and then 9 months and 1 year. So this one kind of goes, this is why I don't, this is not my favorite chart. This has some milestones, which are great. But at around the 9-month mark, I like to ask them, are they starting to pull up? Are they trying to cruise? Because if they're not doing that, then there may be some delays. One big thing to ask is, and I usually ask pretty early, like at 6 months, 3 months even, is if they have a walker or somebody gave them a walker, because it is not recommended by the AAP, American Academy of Pediatrics. Number one, because many ER visits are because of walkers, but 2, because it actually delays development. They're depending on this thing to get around, so they don't have to learn how to walk, they don't have to learn how to pull up and cruise. So I try to tell them very early so they don't waste their money on buying something that they're not supposed to be using. But like kids like fall down the stairs and are like, they're able to reach things that they're not usually able to reach at that age. So lots and lots of accidents that happen with that. But at 1 year of age, they should be being able to talk, sing several words. Even at 6 months, they're usually babbling, saying something, like maybe just one little word, but slowly developing that. And at 2 years of age, you should be able to understand at least 50% of what they're saying. 3 years of age, at least 75% of what they're saying. But you can kind of look through this a little bit more and see what are things you might be looking for. There's another thing called ages and stages that you can look up for each month. It has like a 2-month, 4-month, 6-month thing that you can look to, if you're going in, when you're shadowing with one of us, if you're going to be asked to go into a room, you can always pull up one of those bright futures or ages and stages is one you can pull up to like see, okay, what should they be able to do at this age? Okay, here's some more like specifically about speech that they should be able to be doing. And so kind of an easy, like at 2 word phrases, 3 word phases, 4 word phases, phrases. Gosh. Okay. I thought okay, this one's not very easy to read. So this one I like better. But it shows you the vaccine schedule. So the babies will get a dose of Hep B, vitamin K, and then erythromycin ointment on their eyes when they're first born, like within 30 minutes, usually whenever they're born. And so when they're coming to see you, they come to see you oftentimes they'll be like 3 or 4 days old to see somebody in clinic. And then maybe depending on how well they're doing, 2 weeks and then 4 weeks. But if you're kind of worried about their weight, then it may be as early as a week later than that. But they don't have to get any vaccines during that whole time until they're 2 months old. And so especially right now with like COVID and all those precautions, a lot of parents will ask you, when is it okay for other people to be holding my baby? And I tell them I would wait at least to the 8-week mark. Obviously, grandparents and all that are going to be really hard to keep away. But at the 8-week mark or the 2-month mark, the babies can get their first doses of like the Tdap. So the pertussis is the big one. And that's why we give pertussis to pregnant moms so it's Tdap, but we give Tdap to every pregnant mom. Even if they get pregnant and then a year later they're pregnant again, we give it to them again. Even though general population would be 10 years, right? But this is because of protection for the baby, because it's been such a big deal. So I recommend, I'm like, okay, wait at least to the 8-week mark so that baby can get all of these vaccines, but it still takes another couple of weeks for them to truly get a little bit of immunity from that. But if mom is breastfeeding and if mom got her Tdap during pregnancy, they have a little bit of that other protection. But the other things that they can do is anybody that might be holding the baby, like so grandparents, dad, anything, having them get their Tdap shots, their flu shots, their COVID shots, then that kind of helps a little bit of layer of protection. But this chart's pretty nice to lay out everything. You can see that like they get their Hep B doses, the first, second, third dose, and then the rotavirus and how all that spaces out. And after, you can see that after the child is, so if they go to the doctor at their 4-year visit, then that's another thing that the parents will ask, like, when are they going to have their next shots? It's not usually till they're around 10. If this chart says 11, but a lot of ours will say at 10, they can, so for 6 years, they won't need anything, 6-7 years maybe. Okay. And then the meningitis shot is the only other one you guys have to really think about once they're older. Obviously, the other like annual vaccines and the COVID shot is eventually going to be something that I think will be like the flu shot. We have like a COVID season, like flu season, that I think will turn out to be an annual thing. Okay. So lots and lots of myths that you guys will have to fight. Lots of information that is not true floating around. The things that you do want to warn them about is that the biggest thing that I have the conversation wise is they will come in and say, oh yeah, I gave my baby some Tylenol on the way here. And I tell them that's okay, but next time, let's not give them Tylenol or ibuprofen because we want them to develop that reaction, right? That's how their body is developing that immunity. They're kind of blunting that immune response whenever they do that. And I tell them, let's just go ahead next time, let them have the shot. They're probably going to be a little bit fussy. They're probably going to feel warm. They might even run a fever, and that's all normal. But if it's affecting them so badly and you so badly that they're just miserable, then that's fine. You give them some Tylenol, give them some ibuprofen. I just wouldn't like preemptively do that because some of them will get it and they'll act totally normal, and that's fine. But that's one of the things I warn them about. They might have some mild side effects. They might have a bump or a lump wherever it was given. We get lots of calls about that, but that's all very normal. Okay. So lists of things that people think that it actually might weaken their immune system, or that might give them autism, or that it has mercury in it, that it causes them to have allergies, or it will give them the flu, or it will give them COVID, right? Those are all things that are not true because the way that it's given is, it doesn't work that way. It's pieces of things that your body recognizes. You guys know immunology, but the parents don't know that. And so something that a way that I ask is, when they say that they don't want to, or for whatever, is asking them what, like, I tell them it's fine, but why is it that you are not wanting to give blah, blah, blah. And sometimes they don't have, there's like, I don't know, I just don't want to. And you can't fight that. So do what you can, but a lot of them already have their minds made up. So it's a little bit difficult. This is an interesting question, but yes. Next time I won't insult your intelligence and have this question in there, but I took some of them out that were very obvious, but I didn't catch this one. Okay. So a lot of you guys know all this already. Things to look for, things to potentially learn about. All right. You guys already did your quizzes, right? Okay. Any questions about the quiz? I don't have, oh, I have it here. You guys do have any questions? Okay. If you end up having any questions, you don't understand it, do you guys have the answers?
Yeah.
They are, okay,
I'll see it.
okay. If you, if you don't understand any of the questions or the answers, then let me know. And otherwise, I think we're done. I gave you guys the handout, so we'll put these on Leo, but anything else, any other questions that you guys have? Okay, okay.
If we're
Number 9, 1 second.
I guess I don't really understand what you get.
Okay, let me see. Let me read this case real quick. So
You actually get the process for people generally, or
so that's a good question. So for her, all the other options are definitely wrong, so it'd have to be A, but so in our patient population, it's not very common for us to have a 50-year-old without any risk factors. So I don't know if I've ever had a patient like that. But in general, that's a good question. Let's see if we can go back to, I wonder if it's on this.
I wasn't even sure like why they chose.
Yeah. 55 is kind of the, let's see.
So that one up to 45 and 55. Or, no, it's 35 for that, 40.
Let's see. We should be able to go to That's a slide that should be in this PowerPoint, but it's not. So that's a good question.
I just don't know, like, maybe it's like, so it's an updated since it's been made.
Right.
And like I found a good question, like. The optional questions or like the one answer questions, and screening recommendations, how to do it.
Which one was that? I need to make a note of that. It's okay.
That I can get
It's
to.
okay. That's very possible because there's things that go through here that have been coming through for years and do need to be updated. So absolutely, if you guys come across that, anything like that, I definitely should know.
Yeah, so I think online it says the recommendation is for men who are 35 and older, and women who are 45 and older, or people 20 and above with risk factors. Some heart conditions, this one. Well, yours is too. What you probably want to go off of. This is like the.
Yeah, so I think that's what the first place I looked, I thought it said something different. 1 second. Okay, yeah. That's right. So it should be. So yeah, this question I don't think is correct. I just don't remember it ever. This could be really old. But yeah, so this question probably needs to be changed. So it looks like, just like they said, and so I'm just repeating it for Zoom people. So men greater than or equal to 35 years and older, women greater than or equal to greater than or equal to 45 years of age and older. You screen them for cholesterol. So total at a minimum, the total cholesterol and HDL. We usually just order a lipid panel. And then if they have risk factors, you start at 20 to 35 for women, men 20 to 35, women 20 to 45. Basically start at 20. For blood pressure, you start at 18 for men and women, which we check blood pressure way younger than that at visits. But okay, so this question needs to be changed somehow. Thank you. Sure.
For number 3. I recommend starting like you have to get maybe answers and start at my why did you choose
Sure. Okay, so did you guys calculate the score?
Yeah, I just it was like I think it was like that's if it's over 20, yeah, yeah. That was the reason. I don't think I calculated that, but when I just saw the video, I said that's.
If almost any time, if they're a smoker, it's going to put them over into high intensity. Okay. Any other questions? Nope. Okay. All righty. Let me stop this recording.